Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, my name is Dr. Shanda Blackmon, and I'd like to welcome you to the Baylor College of Medicine On Air podcast series. Today, we are having one of my favorite interviews and podcasts. This has been heavily anticipated. We'll be meeting with Professor David Corry, who's one of our experts. He practices at the VA Medical Center, the Michael E. DeBakey VA Medical Center, which is one of the world's largest VA medical centers. And he also is an expert in immunology and allergy, and he happens to be an expert in fungal sinusitis and how that affects asthma in adults. Welcome.
Thank you very much. Shanda, great to be here.
Yeah. So let's start by talking a little bit about what's your daily practice like, what kinds of patients do you see, and what are you particularly interested in?
Sure. So my practice at the VA is diverse. We see the usual allergy patients, allergic rhinitis probably being the predominant patient that we see, but we have a huge asthma, sinusitis cohorts, so a lot of allergic airway disease, a term I use kind of inclusively to refer to those conditions. Beyond that, we also have the bread and butter allergy conditions like chronic urticaria, food allergies, and that kind of thing. My practice is a little bit different. My background is actually pulmonary and critical care, and I kind of slipped into allergy through the back way, and so I have a more diverse practice. I like to see the chronic COPDers, folks with emphysema, interstitial lung disease, sarcoidosis, some of the bread and butter pulmonary stuff that also get into allergic disease kind of trouble. I see all those patients as well.
So I bet the vets are very fortunate to get to see you because you have such a breadth and depth that you're interested in.
Yeah, so one of the things we can do is we can keep patients and not have to keep referring them to different subspecialties, right? So us and the pulmonary service kind of tussle over, which patients to keep and that kind of thing. It's always good that, to be able to consolidate care. So we're able to do that to some extent at the VA.
Yeah, so I did my cardiothoracic surgery training at Baylor, and one of the best parts of my training was going to the VA. The veterans have to be one of the most pleasant patient populations
Absolutely.
A physician could ever care for, and
it's
an
a great
honor.
Group. Absolutely.
Yeah.
Couldn't agree more.
So when you look at your practice, I think you started to early recognize, maybe even especially here in Houston, there's a lot of fungus out there, this fungal sinusitis, and people really chronically suffering from something that was a little bit uniquely noticed by you, where you started to come up with a unique regimen for managing it, correct?
Correct. People with chronic sinusitis, they often go to ENT surgery first, but a good fraction of them, maybe 30%, will come to medicine first. Okay. The tools that medicine has to combat sinusitis are almost completely ineffective, and that's obviously a frustrating place to be in if you want to take care of this group of people. Asthma is strongly related to chronic sinusitis. Thank you for bringing that up earlier.
Yeah.
And so there has to be a common pathophysiology that links these two diseases. It's well known that effective management of chronic sinusitis, often with surgery, will improve asthma outcomes, and to some extent vice versa. So what we wanted to understand is, why is it that many of our asthma patients, many of our folks with sinusitis, don't do well with the standard therapies, the standard textbook, the GINA guideline-based management strategies that we all try to follow? There's a very significant, it's reported 10% don't respond very well, so they have treatment-resistant disease or steroid-resistant asthma is frequently seen. So really, what is the basis of all that is what we really wanted to tackle. And it just became increasingly sort of obvious that we're missing something very fundamental about these diseases. Fortunately, we have a material that we can work with, sputum, that asthmatics and folks with bad sinusitis produce not all, but many produce on a daily basis. Mm-hmm. And we can study that to try to understand what might be lurking in there that might be underlying these disorders. So it took a while to get used to, doing microscopy with sputum, but one thing that emerges, whether you have sinusitis or asthma, you begin to see fungal forms everywhere. It could be hyphae, it could be yeast, it could be spores, very little in the way of other organisms, including bacteria. So fungus was really the predominant organism you can clearly see under the microscope. So that led naturally to, why can't we, these don't typically grow out when you do the cultures. So we investigated that, and so what we find is that, and this has long been known, but mucus, which is obviously a big component of sputum, is antimicrobial. It suppresses organism growth. That's why we have mucus. It's one of the tools that our immune system can throw at organisms of all kinds to prevent them from growing, creating a hostile environment for these organisms. So if you remove the mucus, we do a chemical treatment step and centrifuge out the organisms. So now it's free of that mucus, and then you spread on your microbiology media. Then you get a very clear answer. The fungus grows like wildfire.
Right. So if you have an impairment of mucus production, or if I always liken this to whenever a kid got sick, the parent would always put the Vicks Vapo Rub on the chest, and there are even some TV shows that talk about this magical rub, which is really Vicks Vapo Rub, and it kind of opens up your sinuses, makes you feel better. But actually, what it's doing is it's paralyzing your ciliary muscles, and it's impairing the delivery of mucus. And so it might actually be making you sicker, if I'm correct.
In the long run.
Yeah.
So it feels good initially, but the long-term consequences are probably going to be negative.
Yeah.
It's the same thing with current management of currently approved and widely employed management strategies for asthma and sinusitis, which emphasize the use of glucocorticoids, and in the form of inhaled, glucocorticoids, oral, et cetera.
Right.
These are all are highly immunosuppressive. They are going to result in an increase in the fungal biomass within your airway over time. So the concern is that.
Hold on, let me stop you real quick. The fungal biomass?
Biomass, yeah. Well,
so it's like a buildup of fungus in your sinuses?
Including biofilms, right.
Biofilms, like if you're cooler, you spill a chocolate milk in your cooler and then your cooler never smells right again. Is that right? Okay, so biofilms, biomass, and you can even have fungal balls inside your sinus, right?
You can have fungal balls in the sinuses and in the lungs. That's a very rare condition, pre-existing tuberculosis.
It's not rare to me. I treat that.
Of course, you see this all the time.
I professionally remove fungal balls.
Exactly.
You prevent them.
Exactly.
Okay.
Yeah. So that's one form of fungal airway disease is the fungal ball.
Okay.
But what we're talking about is airway mycosis. This is not a fungal ball. It is the diffuse growth of the organism in a non-invasive way along the epithelial surface. It's just growing along that surface, not invading beyond the epithelium, except perhaps very rarely.
So is that when you say you're colonized? Is that?
So that gets into a very good point. So people struggle with these definitions. So colonization, classically it means that the organism is there, but it's not really causing a lot of harm.
Right. But it's causing harm.
Here we're definitely causing harm.
So it's like you're held captive. They've invaded your village and they're taking over.
So it is an infection in my book. Okay. So we call that airway mycosis. But if I use the word infection too many times, I get shouted down in national meetings, or my papers won't get published.
Okay.
People don't like that term. So airway mycosis seems to be a term that most people can accept. So that's what we use now.
Okay, it's kind of like when an angry teenager comes back home. They take over the house, and it's kind of like that for a while, and then they hopefully at some time go off to college and come back nice again.
There we go.
Okay. All right, so what do you do about that mycosis?
Right. So seeing all these cultures. So our data are, for example, we're up to 1,100 cultures of sputum at the VA over we did this as-
1,100 patients or cultures?
Not necessarily patients, because some of these
Maybe
patients are
multiple cultures.
have multiple cultures, but at least 700 patients, let's say.
Okay. That's a lot of fungus.
It's a lot of fungus. And so about 97% of those are positive on the first try, just to give you some data and how easy it is actually to culture these things. Keep in mind that the typical microbiology laboratory does not do the chemical treatment step to try to remove that mucus. So most of the time, your results coming out of the microbiology laboratory for sputum is going to be negative. You're not, even if it's a bacterial pneumonia, that's ripping pneumococcal pneumonia or TB, the chances of you actually having a positive result are low, well under 50% because of this issue.
TB takes 6 weeks to grow,
and
right?
It takes forever to
grow.
And you need 3 attempts.
Yeah.
Even to get to its 70% yield, you need 3 attempts. But we're at 87% yield on our first try. That's the big difference that makes of getting rid of that mucus.
Okay, so you get rid of the mucus, you diagnose the mycosis.
And so we put folks on antifungals. So that's kind of our main go-to
so
medication.
Diflucan or?
We'll do that. Diflucan is particularly good for Candida, and Candida is our most commonly isolated fungus from the airway, whether you have sinusitis or mold. In fact, our data are 2/3, it's about 1/3 mold, pure mold, 1/3 pure yeast, often Candida. We can't speciate though. That's very expensive, and I'm doing this off of my dime. So just plain culturing is pretty easy and inexpensive. We can't speciate, but so some kind of mold, some kind of yeast in pure form, and then the third category is mixed. So a third people have both yeast and mold coming out of their airways.
So I'm imagining that like a human is listening to this podcast, and if they're from Houston, Texas, they're especially in full-on panic mode at this point because there's a lot of mold and yeast in Houston, Texas, right?
As I explained, my patients diagnosed, I could see those eyes getting bigger and bigger and bigger. What?
Yeah.
I've got an infection now with a what?
Yeah.
And then I start talking about antifungals, medications most people have never heard of, and they really get confused. So it's kind of a new territory for most people, absolutely.
Okay. All right.
But we typically use antifungals. And so if the culture does come back pretty much pure yeast, it looks like Candida albicans, we'll go ahead and do that fluconazole. Fluconazole does not work very well against molds in most cases.
Right.
So we don't use fluconazole that often. There's another big problem with using drugs in the class of fluconazole, the so-called triazoles that include things like itraconazole, fluconazole, voriconazole, posaconazole.
Right.
These are all not so good for veterans who are on medications that largely preclude them taking an antifungal at the same time. For example, cholesterol-lowering medications cannot be taken at the same time that you're on a triazole class antifungal. Many mental health related medications also cannot be taken at the same time. HIV medications, many of them cannot be taken at the same time you're taking an antifungal.
Okay.
So we found an antifungal that not only is well tolerated and highly effective, but it avoids a lot of the drug-drug interactions, which can be very problematic, and that is terbinafine. That is approved for toenail fungus by FDA, but we found that it works quite well in the majority of our patients. Terbinafine, right.
Right, good. Okay, so they get a treatment with terbinafine, and then they might have resolution of this hostile invasion of their mucous membranes. That is our goal. The way I explain it to them, this is our therapeutic goal. We don't always get there on the first try. Yeah.
There's a lot of resistance to antifungals, and terbinafine is not the most effective antifungal. So what I try to warn my patients about is, we go in 90-day steps, 3-month steps.
Okay.
It's a very slow. It's like treating tuberculosis, which can go for quite a few months.
And for TB, you have to do multiple drugs all at the same time, monitor for compliance. This
Precisely.
is hopefully a lot easier than that.
It's easier, but there's a lot of overlap with that, and so the chronicity is something that folks have to be educated about and have to be warned about ahead of time, so they will be compliant. So we're not looking at 2 weeks like your ampicillin, prescription. We're looking at least 3 to 6 months. For sinusitis, that's more like a 1 to 2 year program. It's much harder to treat sinusitis than it is asthma, interestingly, is what we're learning. We don't quite understand why that is.
Yeah.
And we have to be, and then, we have to, it's important to find clear goalposts, to know that we are achieving, efficacy here. So resolution of clinical symptoms, cough and phlegm production, that's a no-brainer. Other things like congestion, headache, and then the maxillofacial head CT scan, are all of these improving or not? So these are some of the things that we can follow and helps us to guide management.
And it also sort of rules out that presence of a fungal ball, too.
Absolutely.
Which I imagine these drugs aren't going to take care of a huge fungal ball.
Exactly right. It's funny. Thank you for bringing that up. You know that antifungals are not that effective in lung fungus balls.
No.
And fungus balls in the sinus have a very characteristic radiographic appearance, which we almost never see. They're very, very uncommon. But I think it might be a similar pharmacological issue, and that's why antifungals are less effective in sinusitis, because it may not be a radiographic fungal ball, but it's the same kind of issue. It's that fungus is existing somewhere in some thick mucus layer that the antibiotic is not penetrating into.
Right.
So we think that's actually a big part of the problem.
Yeah.
And that surgical debulking actually is probably the best way to get to rapid improvement. Not only will surgery frequently give them immediate improvement, but then it's easier to clean up the residual fungus that the surgeon cannot completely clear out with our antifungals.
So is that like unroofing the sinus,
Basically.
making it easier to exit, and then like pressure washing the inside to get all that
That's exactly
out
right.
and
Exactly
removing
right.
a fungal ball if it is present?
Exactly right.
So I always thought about this when I was living in Houston doing hot Bikram yoga, right?
Mm-hmm.
So you're in a hot, sweaty room.
Right.
You're near this like surface that smells kind of like a fungus, and you're like just like deep breathing it in, pulling in the spores, exhaling. So I wonder if there's a correlation with that and your sinusitis. But I imagine maybe not a lot of your vets are doing hot Bikram yoga.
Probably not.
So maybe we'll have to get Dr. Evan Lee to look into it.
There we go. Are you implying that the fungus is maybe in the water, or that's associated with these rooms?
I think it's in these rooms where there's just chronic
humid,
sweating,
right?
and the room is like 90 degrees.
I'm
it's
with
heated
you.
up. It's like if I was going to build an environment to grow fungus, this is how you would do it.
That's exactly right. And
Right.
I basically stay away. I love taking saunas as much as anybody, but I basically stay away from hot tubs, saunas, for exactly that reason.
Yeah.
So what I tell my patients is, and my trainees, learn to trust your nose. As long as your nose is open and you can breathe. We have a very sensitive nose for detecting fungal odors, and probably for a good reason, because we need to be aware that fungus is growing. It's protective. You need to get out of that room. So it's particularly when shopping for a new house. I tell my vets who are frequently doing that, just take a step in, take a sniff. If you smell that damp, moldy, musty kind of thing, just turn around, walk right out, and say, "See ya."
So what about my son's car if it smells like that? What do I do?
So frequent problem with
change the filter.
Yeah. The air conditioning systems in cars are a big problem, and you got to change that filter.
That's where it's coming from.
Exactly.
So you got to change the filter. So we have lots of public service announcements in this podcast.
We're getting them all in.
So one of the things that we talked about in December, we did a strategic retreat for the Lung Institute. And Farah really brought up this wonderful idea of doing a whole course to teach other pulmonary, allergy, immunology experts around the country and maybe even around the world how to treat this using your regimen.
Sure.
Is that something that you think would be interesting to do? Because I think
it'd be a fantastic idea.
I think we should do this.
So we are training our fellows as best we can, and we just turned over our fellows, of course, in July, and I was just absolutely delighted to see that our fellows we've been working with for a couple of years are really pretty comfortable prescribing those antifungals and getting really tremendous results. But it's something that needs to be incorporated formally into a training program. This is not easy. Yeah. There's many things that we do that are not in any textbook. We just learn through hard knocks. You got to treat much longer than expected, like for 1 to 2 years or more.
Right.
You have to watch out. There's some side effects that are not in any textbook, like for example, the Jerisch-Herxheimer reaction, which is famous for penicillin in the case of syphilis. This was discovered in the early teens, I suppose. Presumably it's the organism lysing due to the antibiotics and releasing toxic substances that lead to these very strong reactions. In the case of fungi, those toxic reactions amount basically to anaphylaxis, and so it can happen at any point.
Wow.
In the first 30 days, maybe about 5 to 10% of patients have a bad reaction. And I just got sick and tired of realizing that I put this guy on terbinafine, and in not 6, but maybe 12 days later, he's in the hospital with anaphylaxis. And
So
he's
do you
mad
give
as
everyone
hell.
an EpiPen?
So we put people on EpiPens, and we give them prednisone. So we give them a week of prednisone, not to be taken, just sitting on that shelf, unless they have one of these severe reactions.
Yes,
So
when
then
they start
then
having the reaction, you put them on the steroid
to
and
try
that
to cool
helps.
that down, prevent them from having to go to the emergency room. We give our folks handouts and that kind of thing to explain these possibilities. We talk about this in clinic, but this is pretty strong medicine, and so we need to take this seriously. I think it needs to be part of a training program. But what do you do about the practitioners that are already out of training and that kind of thing? So we'd like to organize some kind of a Baylor sort of training that could be maybe put onto YouTube. Maybe it would be a live thing. We have to maybe work out those details.
Yeah.
I'd love to talk to you about that some more. But some kind of a training program that would go beyond just what we do for the fellows, so anybody could learn how to safely use these.
And maybe CME, so you get the credit
Exactly.
for it, and maybe
Precisely.
even a certificate that you're certified to treat. I mean, if I were a patient, I wouldn't want to go to a thoracic surgeon and have them operate on me unless they were board certified.
Absolutely.
And if I were a patient going for this type of treatment, I wouldn't want my doctor to watch a 1-hour podcast and then go out and treat me without really understanding that I could go into anaphylactic shock, or
Absolutely.
that there are some consequences of this treatment, or how long, what's the duration of treatment, or how do we know if it's working. So I think you're absolutely right. We need to do this.
So we're in discussions with the CME office here at Baylor to try to pull that together, and so we hope to get that going pretty soon.
Absolutely. Well, I look forward to it. I'll take your class, even though I probably won't be prescribing it, but I'm going to be referring people in for you. So
Perfect.
Lovely. Well, anything you want to say at a last minute as we close off the podcast?
Just thanks for the opportunity for me to talk to you about this program that we hope to have up and running maybe in the next year.
Yeah, it's going to be so fun. I can't wait. So thank you so much for joining us for the Baylor College of Medicine Lung Institute On Air podcast. We look forward to seeing you next time.